Brian Allen. I'm the moderator of the panel, and I know we're in Vegas, and they say what happens in Vegas stays in Vegas, except for this panel. We want you to learn something from this, take it home, talk about it, implement it, use it. Hopefully it'll be beneficial to you, and you'll learn some things that'll help you really manage costs. I'm going to now let the panelists each introduce themselves. Dr. Tonn, we'll start with you.
Dr. Melissa Tonn. I am the founder and chief medical officer of OccMD. We're based in Dallas. We are really the only physician-led nurse case management company in the workers' comp space, and we do workers' compensation for the last 24, almost 25 years, have worked with the majority of employers who have elected an alternative to workers' comp in Texas and have an injury benefit plan. So we look at outcomes of both physicians and patients on a daily basis, and have worked with optimized outcome with Brian on a number of very challenging cases. So good morning.
Well, and one thing that she didn't mention that I will, because she's too humble to do this, she was a comp lauding winner, was it last year or 2 years ago? So she's recognized in the industry, and we really appreciate her efforts. She's kind of a pioneer in some of this area. So Dr. Scott, what do you want to?
Good morning. I'm Scott Roloff with IntegerHealth, and what makes IntegerHealth unique is that we quantify healthcare outcomes. So what do I mean by quantifying a healthcare outcome? Well, you can think of healthcare as an equation. You have your inputs, and you get your output. The inputs are the dollars that you pay to doctors and hospitals. Then how do you measure the output? The traditional way to measure outputs in healthcare are through quality metrics, which focus on the process, what a doctor did or didn't do. Did the doctor comply with clinically based guidelines or evidence-based medicine? Did the hospital get a good HEDIS score? Or did the patient like their doctor or their healthcare experience measured by Press-Ganey and CAP scores? And that has as much to do with how long they sit in the waiting room than anything else. And those quality metrics, they're just proxies for what really matters. And what really matters is the patient's outcome. Did they get better? And if they did, how much did it cost and how long did it take? And that's what we do at IntegerHealth. We quantify healthcare outcomes by combining cost and quality into a single dollar value. Now you can compare the dollars that you got to the dollars that you spent to get it, calculate your returns and your ROIs, and you can evaluate and rank things based upon the outcomes they had paid. Who's the best primary care physician in your network for shoulders? The best surgeon for knees? Which hospitals are getting the best results, diagnosis by diagnosis? On treatment patterns, you can evaluate your back patients. Are getting better outcomes by sending your back patients to physical therapists or chiropractors. You can even evaluate your workers' compensation adjusters. Who's the best adjuster, getting the best outcomes overall and injury by injury. So that's what we do at IntegerHealth. We quantify healthcare outcomes.
And what Scott's also too humble to mention is one of the studies that we're going to be discussing today won an award just within the last few weeks, right?
A week ago.
Yeah. Okay. Great. So we'll share more about that when we get there. But, Harvey.
I'm Harvey Warren. I'm the author of The Optimized Patient. I don't know a whole lot about workers' comp, but I know very much about getting hurt and getting better. And along the way of getting better, I realized that there was a gigantic missing element in patient education. And I set about writing a book as I'm a writer by trade. And the book, The Optimized Patient, became the core intellectual property for optimized outcome solutions. All of these individuals have been involved in the development of a more comprehensive way to manage the wild card in the equation, which is your patient. The injured worker is the wild card. You can get them the best doctors, you can get them the best PT, all the meds you want, but if that person has the wrong mindset, they get depressed, they just won't eat the right food, they don't get the proper rest, they don't move around and get their blood flow going, they are going to get better over a very long period of time, which is apparently not a good idea for workers' comp payers. So our idea is to help you improve your bottom line by focusing on outcomes rather than inputs.
And Harvey has a few books up here that we're giving away, and he'll sign them for you if you're interested.
If wants to sign book, I'll be glad to give you.
So, and Blake he's filling in for Dr. Sullivan. We appreciate you being here. So Blake, go ahead and introduce yourself, please.
Sure, yeah, hi, Blake McWilliams with OutcomeMD. A live arm from the bullpen today. Dr. Salvin couldn't make it, but I'm the VP of Sales with OccMD. I'm relatively new to the team, but I've been in the health data space for almost a decade, primarily focusing on patient-reported outcomes collection, which Dr. Salomon mentioned. And again, these are patient-reported outcomes are from medical literature. These are questionnaires that patients complete pre and post-treatment, say for a fracture, and they are quantified, or they are validated instruments of measurement. They produce a score. So these are objective measurements of pain, function, quality of life, and recovery. What makes OutcomeMD different is the patient experience that's provided digitally through the platform. Patients are shown their improvement. They're not shown, p-values and complex statistical analyses. They're shown improvement in a very simple interface. So patients want to see how they're improving. And what also makes OutcomeMD different is that patients, providers, and other stakeholders, maybe case managers, can add confounding factors. Why is my fracture patient, not showing the improvement that we expect at the 4-week period? Well, it's because they went on vacation and blew out their knee, and we didn't know that, but the patient was able to add that to their OutcomeMD data interface. So the ability to add confounding factors is really what sets OutcomeMD apart in the industry. But happy to be here. Thank you.
Hey, Justin Salomon here. Sorry I can't join the panel, but I did want to send a quick video talking a little bit about work comp and OccMD and the concept of tracking patient-reported outcomes, correlating them with medical record data and confounding factor data, which we also obtain from the patient and structure, in order to deliver something that truly changes the game for the provider and patient and administrator and care manager and the workers' compensation companies who want the workers to get back as fast as possible, but also as well as possible so that they're fully productive and happy. I started OccMD to help providers and patients quickly and objectively understand their symptom severity and keep track of how it changes over time. The software does that, plus it layers in timeline visualization of care, which brings electronic medical record endpoints and the confounding factors and the outcome data, all on an outcome timeline, so you can see how they've changed over time. A best practices dashboard. We have outcome marketing, which is good for the doctor, sort of brands them for quality. And we track some unique data points like confounding factors, adverse life events and stresses, social determinants of health, new injuries. If I replace your right hip and 6 months later you break your right ankle, it looks like I did a bad hip replacement, right? Because your pain is up and your function's down. So we keep track of, did they have any new injuries, right? And this comes from the patient, a lot of this information. And ultimately, we can deliver real data to the clinicians, the patients, and the work comp administrators in order to really understand what's happening and to be able to make sure that patients get the best outcome the first time. From a workers' comp standpoint, there's notifications when patients are starting to crash a little bit, when they're doing poorly and getting worse, and the clinician can intervene early. That's actually been shown to improve outcomes. Tracking outcomes actually improves outcomes. And even just dialing in best practices, knowing what works and when it works and in which provider's hands it works best may help work comp know that the rotator cuff should go there and the ACL should go there. In the end, what we all should be doing is measuring patient symptoms and quality of life before we treat them, in fact, to inform whether and how we should treat them, and then keeping track of how that changes over time so that we can look at the cumulative data and really understand what's working and what's not working. So I hope you enjoyed the panel. Blake will do a great job representing OccMD and to answer any questions you have around the importance of measuring what matters in healthcare, which really is patient-reported outcome measures. Last thing I'll say, these come from the medical literature, right? They're objective because they are validated and compared against other ways to determine an outcome. So a patient-reported outcome measure, and we have them for every condition in medicine. Literally, there's a way to measure every single condition with this thing. And then we boil it down into a symptom score that's easy for the patient and provider to quickly understand. So anyway, I hope you enjoy the discussion, and again, I'm sorry I'm not there, but I miss being there, and next year for sure. Take care.
Thank you. So we're going to try to just pull kind of all these different pieces together and talk to a little bit about how You know, we're so good in the industry at focusing on the cost of inputs, like, well, we can reduce the cost of this procedure by $25, reduce the cost of this pill by $25, but does that always equate into savings? Are we, are we really cutting costs if we do just that? And really, the real savings is how do we manage to a better outcome? And I think Dr. Tonn in a recent article said it best: the evidence is in the data. So we're going to look at some of the data from their experiences and talk about what that means. And I'm going to apologize in advance. I'm going to crane my neck a little bit to see that screen because I lost my TV monitor up here. Anyway, so we're going to talk about, first of all, measuring inputs. So we have fee schedules, we have contract rates, we have service costs. You know, those are all things that we measure in the industry going in. And then outcomes, data. We want outcome measurement to be data-driven. We're looking at disability duration. We're looking at return to work. I think Scott Roloff mentioned that, getting the patient well. Dr. Tonn mentioned getting the patient well. Harvey mentioned getting the patient well. And Blake mentioned, getting the patient well. That's the ultimate measure of outcome is getting the patient well and getting them back to work. So how do we predict outcomes? So in the early claim analysis, I think it's kind of an art and a science. I think sometimes there's more art in it than science a lot of times. But in the early claim analysis, I'm going to just ask the panelists, what do you look for? Like, when you're looking at a claim and trying to figure out what do I do with this particular claim, how do I know how do we figure out is this a claim that's going to go off the rails? Is it one that's going to do pretty well on its own? So Dr. Tonn, when you're looking at the initial claim, how do you kind of evaluate where you think it's going to go?
Well, if we actually think about occupational injury cases, over 80% of what's filed as a workers' compensation claim is someone who is merely experiencing symptom or discomfort that they equate to the performance of a usual work task. It is not a catastrophic event. You have your slip, trips and falls, you have your malfunction of a forklift, but the vast majority of the claims are just a lifting task or something they have done every day. And so when we start out looking at claims, we look at what the alleged mechanism of injury is, whether or not we have any exposure in terms of employers who are outside of workers' comp, where negligence may be a question, and then we start working up what the extent of injury is, taking into account the whole person, which will include then looking at what came before. So we go after past medical records much more aggressively than most people do in workers' comp to come up with an idea of what we're dealing with. Now, we don't do that if we have severity on the front end and we have someone who has a tendon laceration or a fracture, we get them immediate care with the right doctor at the right time. But that's not the majority of the cases. So looking at the extent of injury, doing a causation analysis is paramount to a lot of our outcomes.
Harvey, in your experience working with patients, what do you see early on, and what are indicators for you on how that's going to go for that injured patient?
Well, as a person speaking to peer-to-peer to injured workers, they're typically lost in the process. They don't know what the heck is coming at them. Most of them, I don't know about all. Can I have a show of hands? How many people took surgery 101 when you were in school? Nobody. Nobody really knows how to deal with a very serious injury and what's ahead of them. The doctor's given them whatever the fix is, given them a thing if you get high fever, diarrhea, vomiting, redness, whatever, call me. Otherwise, that's the extent to which they are educated. Now you got to go figure out, well, how do I get better from this? Then you're going to go on the internet, and 95% of what you're going to read is marketing, and it's a problem. Typically, the first thing I say to people on the phone is, are you committed to getting better? That brings about a big pause. They go, huh? What? I say, are you committed to getting better? Are you willing to do the work? Your job right now is to do the work to get better. We're going to give you the education and support you need. We're going to call you every week. We're going to send you videos and audios. We're going to give you a nutrition plan. If you'll do it, you'll get better faster and stay better longer. If you don't do it, well, you'll have the typical recovery. So for you guys as payers and providers and people that manage care, know that your injured worker has no idea how to get better. They are clueless, and if you're not educating them, it's a problem.
Blake, from your perspective, so you're looking at patient self-assessment scores, things that patients are self-reporting. What do you see in the early part of an injury recovery that gives you a clue as to where that might end up?
Well, yeah, I think a lot of from a data perspective and from a data collection perspective, because we work with a lot of providers around the country, as well as case managers on the employer side. It's all about using that data in an aggregate sense to set expectations. Like Harvey kind of said, excuse me. Surgical patients or work comp patients, if they're going into surgery or have a severe injury, they don't, especially if they've never had a medical episode or experience, they don't necessarily know what they're getting into. But if providers or case managers are using data to set expectations, it's going to lead to a better outcome, because improvement and recovery does not necessarily equate to getting back to my life the way it was. We want to show improvement and recovery in an objective sense. We want to manage what we measure by collecting data so that we can show the patient, hey, you can expect about an 85-90% function in your knee within 12 to 18 months, right? That's based on data. That's not perfect. It's not full-blown back to where you were maybe, but it's recovery and you can return to work. Those are two things that can be true and held delicately. But if a provider articulates that properly to a patient or a case manager based on data and in the context of the education and the support and the peer-to-peer that Harvey's talking about, the patient has a much clearer idea of what they're getting into. And then we continue to measure throughout recovery, and we continue to educate throughout recovery, and maybe that 88, 85, 90% boosts up to 100 based on the fact that the patient is consuming education and doing all the right things, and we continue to measure. So I think setting expectations using data is a huge thing, and it doesn't take long, but it's a huge element that providers and case managers could take advantage of.
Scott, you're looking at a lot of data. What do you see in those early stages of a claim to kind of give you a picture of where it might end up?
Well, I actually have a conference handout that has the case studies that we're going to talk about a little later on. You can download it off the app, or if not, you can email me and I'll send it to you. But in that package is also an article we recently published a couple months ago entitled "Predicting Your Next Big Workers' Compensation Case While You Can Still Do Something About It." Now, I'm not going to go through the whole article, but the gist of it is there are ways to use artificial intelligence to predict when a case will become an outlier almost as soon as the injury occurs. And what is an outlier? Well, it's one of those cases that careen out of control. They cost multiples of a typical case. They take much longer to get the person back to work than is typical. And the gist of the article is you take your historical data, your medical claims, your loss runs, your indemnity data, and you marry that up with the adjuster notes on that case. And then using artificial intelligence, machine learning, natural language processing, you go through and analyze the adjuster notes on the cases, specifically those that you know later became outliers. And you use keyword identification, semantics, tone, and you find out what's typical in those first adjuster notes for the case that later became an outlier. That's your AI learning phase. After that, you take your AI platform and you integrate it into the program into which your adjusters are typing their notes. So when an adjuster opens up a new case, they begin typing those first adjuster notes on it. The AI platform is analyzing those notes based upon what it learned from the historical cases, and it can spot, based on the way the adjuster is typing those notes, is this case a potential problem? And then in real time, it can send a warning back to that adjuster, telling them this is a particular problem case. You need to pay specific attention to it.
Thank you. Harvey?
Let me jump in the other end of that. From my perspective, when I see that a patient's not answering their text or opening their email, I'm pretty sure I got to call Brian and say, hey, we need to contact the case manager. This person is not engaged in their recovery. And I think that's the core of what we're talking about.
Yep, thank you. So, I guess in Indian, Scott, you addressed this a little bit. How does past performance on claims predict future outcomes? And you talked a little bit about AI, which is, do you want to elaborate on that at all at this segment? A little bit about just, because you can kind of look at there's factors, there's commonalities, I think, in cases where they do go south. So how does your data inform that and that from the AI perspective?
Well, from the AI perspective, first of all, kind of backing up, as a data analytics company, we have to define what a good outcome is. And in workers' compensation, a good outcome is the employee being at work. And then what we do in quantifying analytics is we accumulate all the costs to get and keep that employee at work. Those are all the medical and pharmacy costs and all the absence costs, what you had to pay that employee while they're out of work. If you're an employer, you can get that out of your HR records. If you're an insurer, TPA, you can use the lost wage indemnity payments. And then you can slice and dice things to quantify the outcomes. For example, take a knee surgeon. We'll know what the average cost for a knee surgeon is to get someone better and back to work. And if we can, we'll risk adjust that data. What do I mean by risk adjustment? Well, you have to give credit to doctors for taking care of more complex patients. If you got 2 employees with knee injuries, one is 20 years old and runs marathons, the other is 60 years old, works in a cubicle and has diabetes and obesity, we know it's going to take longer and cost more to get that senior citizen better. So you have to assign a risk score to level the playing field when you're comparing the doctors, one to the other.
I'm the second guy.
Yeah, you're the second guy?
Yeah, I'm not running marathons.
Well,
I'm the other guy.
To answer your question then, we'll know what the average cost is for a knee surgeon to treat an average knee surgery. Then if a particular patient goes to that surgeon, if we know that what that patient's risk score is, that they're diabetic and obese, we can adjust that specific average for that particular patient and make a prediction. What will this particular knee surgeon do with this particular patient? We can predict their outcomes that way.
And Dr. Tonn, you're in the trenches with the patients. When you're looking at past performance and how does that inform future claims? What do you look at? What are you looking at in your practice that helps you understand where a claim might go when you're first getting it?
I'm going back to being 60 and being geriatric. I've got an issue with that. So I want to back up from what everybody said here, because there is a lot of literature on the fact that arthroscopic knee surgery in those who have arthritis or degenerative meniscal tears is by definition low value care and should not be operated on with much frequency. So the issue shouldn't be that AI can predict what the outcome is from a surgeon who's doing a surgery that was wholly unnecessary. And what we have done over decades now is if we have somebody over the age of 40, we get bilateral knee, bilateral shoulder, bilateral wrist MRIs. And having looked at tens of thousands of these comparison images, have a data set that shows what the natural process of aging is, which in shoulders includes rotator cuff tears, in knees it includes meniscal tears, and in wrist it includes triangular fibrocartilage tears. So a lot of time and effort is spent on changing physician behavior related to operating on patients who are operating on the normal anatomy for their age and for their comorbidities, and looking at those outcomes and measuring return to work when they never should have been taken off of work to begin with. If they had injured themselves with the same mechanism in their garage at home, they wouldn't have gone to seek treatment. They would have taken an Advil, put ice on it, gotten over it. So a lot of what goes on in this industry is wastefulness, and it's everybody trying to follow the money and make a dollar on saving, when if we took a step back and said, okay, wait a minute, what is actually the occupational injury at the end of the day? What does the employer actually owe for, is the question. And that's what we need to be measuring.
Thank you. And Blake, from your perspective, as we look at past performance of providers, is there any information there that can help us predict how they might do with a new patient in their treatment? You're collecting data on patient-reported outcomes various physicians. How does that help inform future performance of that provider?
Yeah, I think it can very objectively inform future performance, especially if you have available confounding factors and comorbidities correlated with your patient-reported outcomes. For let's stick with the musculoskeletal examples that we've been following. For sprains and strains or fractures or even joint arthroplasty, if you boil it down by certain procedures, if you're measuring outcomes, if my average 12-month post-op score for a knee replacement is a 76, how can I use the co-founding factors available to me to improve that score, to take into account patient comorbids and other factors to say, I want to improve that score. Maybe it's technique, maybe it's expectation setting, maybe it's education. There's a lot of elements that could be used to inform improvement. But again, you can't manage what you don't measure. So if you're measuring those scores from a provider perspective, you can take into account the data available to you and seek improvement.
And then Harvey, from a patient perspective, from an injured worker perspective, their past history, their past performance. So is there a difference between someone who's fairly physically active in how they might approach their injury recovery versus someone who's more sedentary in their lifestyle? I think of the person sitting around eating Cheetos and watching Dr. Phil. That's kind of my favorite analogy. I mean, how do those inform how they might perform in a patient education program?
Well, yeah, in a sort of a casual conversation, peer to peer, you start asking people about, what happened, are you okay, you're getting the service you need, and just that alone, that engagement, that communication loop brings people right out to go, oh yeah, I'm feeling down about it, I'm feeling bad about it, I'm feeling depressed, oh my God, I don't know, what am I gonna do? And they start having a conversation, well, do you cook, do you eat out, what kind of, do you exercise, how you're moving around, and you start explaining to people that, they say, yeah, well, you should stay active, you should move around. They go like, why? I say, well, it's about blood flow, it's about oxygenating your injury, it's about how you recover. Oh, there's a real reason for it. It's not just you should move around because we said so, You start talking about nutrition and things that are good for people. Well, I don't really cook. Well, hey, do you know what kefir is? How many people in the room know what kefir is? Seriously, anyone know what it is? One person, 2 people, 3, 4 people. It's liquid yogurt. I said, well, do you have a blender? Can you put a banana and kefir in a blender with some berries and press a button? That's all you need to do. That'll improve your microbiome. That will hasten your recovery. And people will start to engage and go, oh, gee, there's better things for me to eat. There's better things for me to do. So whatever my lifestyle is at the moment, I have to realize I'm in a different world now. I'm broken. I'm hurt. I'm injured. My body's trying to repair itself, and there are things you can do to help it, or there are things you can do to hinder it. We want to advocate with you to help it, and that's our discussion with them.
So all of you are looking at data. You're all looking at data points. Are there things in those numbers that you're looking at that tell you what are the pitfalls? What are things that we should look at? What are the red flags? And how can they inform the case managers and the others working with the injured worker on where they need to spend their focus? And so, Dr. Tonn, I'll start with you on this one.
Well, you look at data points. One of the data points I look at is the number of times somebody goes to an occupational clinic or an urgent care. Who in here would go to an occupational clinic 11 times? Anybody? Would you sit for an hour and a half or 2 hours to go for a visit that probably lasts shorter than a Disney ride? Mm-hmm. And what is the ultimate outcome of that office visit? Does it move the ball forward? Are they reporting improvement? So they're going to the clinic all the time. There's no change in their status, in their level of pain. There's no change in their work status, and they keep telling usually a nurse practitioner or a PA, that's what staffing the clinic these days, that, it still hurts, so they keep getting told, well, if it hurts, just don't do it. And so we have this foundation, that Harvey is building on where, this is where we get to that mindset where somebody has to fix me. And so looking at those little data points makes a really big difference on the front end. So the earlier we get cases, the earlier we can make an intervention, the earlier we can move them from that kind of medicalization, somatization world to a more active, get out of the system. We've established that, it's not as bad as you think it is, and move on with your life.
You kind of touched on something that I complain about a lot, is that the way we market healthcare in this country, we tell people, well, if you take this pill or you have this procedure, all your problems are solved. And they're not engaging in their own recovery. They're relying on someone else to fix a problem that they should be working on and fixing themselves.
Well, if you look at the waste in physical therapy, who established that every case needs 6 visits of physical therapy? Physical therapy is a profession. Physical therapy doesn't make, certain things like sprains and strains heal any faster. Physical therapy is for mobilization. Physical therapy that would actually be more beneficial is exercise. But nobody wants to hear that. Is you get one, session of here's the 5 exercises you should be doing to, keep your function in that extremity, and you don't need to keep coming back to see me. Well, why is that? There's no money in that. So that's, a lot of waste in the system.
Yeah, I understand the exercise part, because whenever I get the urge to exercise, I just lie down until it goes away.
Yeah, take it easy, right? Yeah, I would like to just say something about that. How many people know what ERAS is, Enhanced Recovery After Surgery? Are you aware of that methodology? No, yes? Anybody? Heard about ERAS? I mean, there's a lot of really good research going on in terms of what patients need to do if they've had a major insult. What's going on in your body? And it's an emerging, science. ERAS, there's a guy named Dr. Wishmeyer that we follow at Duke, who's kind of really revolutionizing the way surgery is done in terms of what happens before and after surgery. My book, The Optimized Patient, was essentially about how to become a person in the best conceivable shape before you walk into that operating room and have a spine surgery, which is what happened to me. 7 hours of spine surgery will take a little energy out of you. And the recovery on that is pretty steep. But if you're properly prepared, here I am. I've recovered from it in ways that my spine surgeon said it's remarkable how you bounced out of that surgery. It's crazy. And it's only because I was prepared for it. So the data points in terms of what's predictive of an outcome, how prepared and how engaged the patient is from my perspective.
Okay. And Scott?
I'm not a doctor.
Yeah, I know. I keep saying Dr. Scott. So tell me, you're looking at tons of data. I mean, that's what you do. How does that data? are there red flags that you see in data when you can see, I start seeing this trend and these problem claims, these go south?
Well, I'm going to flip that around a little bit. In data analytics, the more data you have, the better. The problem is not enough data, usually. We call it the N problem. It's ubiquitous. N stands for number. So say you're looking at knee surgeons. You're going to have some surgeons in your data set that do a lot of knee surgeries, and some only a few, at least a few that you're aware of. If they're a surgeon, they're probably doing a lot of knee surgeries. The problem is they're doing those surgeries on folks that aren't in your network in which you don't have the data. So if you got a knee surgeon that does 2 knee surgeries, that's not enough to really evaluate them. We like to see a minimum of 5 and hopefully more than that.
How many were in the Ohio study?
3,100.
What was the result of that?
What, the Ohio study?
Yeah.
Well, the pilot of the Ohio study were returned to work by 30% across the board and saved $2.1 million.
How'd they do that?
They streamlined everything. I think that's the next slide. You want to
Yeah,
get into that now?
We'll get to that. Yeah,
everybody.
So I just want to touch on another point, and I'll segue into this with Blake. Provider performance has an impact on outcomes as well. And I think a lot of times, we talk a lot about the patients in the world that I'm in, but provider performance is a big deal. And Blake in OutcomeMD is measuring patient-reported provider performance, I guess, based on outcomes. If you're a patient and you're looking for a provider, or if you're a case manager looking for a provider, and you're seeing high patient satisfaction scores and good outcomes versus low incomes, what does that tell you? If you're getting low outcomes, consistently low outcomes being reported and dissatisfaction, that's probably a red flag, I'm guessing.
Could be, if they're collecting it and if they're promoting it and if they're publicizing it. There's a great group in Southern California, DOCS, D-O-C-S, if you Google it, surgery group in Southern California that promotes their outcomes on their website, objective promotion of data for hip, knee, back, spine. But yeah, it's very plausible that a doctor could have high satisfaction scores but low outcomes. Maybe they have the best bedside manner and somebody you want to play golf with, but for whatever reason, they're not very good at replacing knees or healing fractures, and that's unfortunate. And I think, again, with the musculoskeletal examples we keep sticking to, you want somebody who's going to get you to return to function, return to work, and maybe you're willing to accept less of a good bedside manner. But yeah, experience, satisfaction, and outcomes are two different things, experience and outcomes. So yeah, there's a lot of elements of those data points that can be used to evaluate providers for both patients, case managers, but again, not that many providers are out there collecting and publicizing this data.
And Dr. Tonn, in your world, you're looking at lots of different providers on your panel. How do you go about evaluating them and figuring out which ones are really good at what they do and which ones aren't so good?
Well, the ones who really intrigue me are the ones who are the most honest with the patients and have a ability to explain to patients that here's what you have, and set the expectation that, okay, if I do surgery on your shoulder, you are going to have to commit to significant time and rehabilitation efforts because you have so much underlying arthritis, because you have, had surgery before. And, if you're a plastic surgeon and you're, going to do a facelift and you set the expectation that the person's going to come out looking like Angelina Jolie, everybody's going to be disappointed. And so you don't want to do that. So the ones that we look at are, how well they communicate what the expectation is on the recovery. They also communicate very specifically what they are going to provide as post-op narcotics, which is a very significant conversation. If you don't set the expectation preoperatively that you're only going to get one pain medication fill after the surgery, that can result in a number of the problem outcomes that we see along the way.
So that physician communication is a big deal.
I would add to that too. In the context of returning to work and work comp, I wonder, and you guys know more about work comp than I do, but if you broaden the timeline for measuring recovery, yeah, maybe you're back to work, but maybe you're still on that one script that you were given. You're back to work, but then the script runs out, you take a nosedive emotionally, you're depressed, you're anxious. What's your performance like? What's your quality of life like, even though you are binarily yes, no, back to work? Those are things that you can also measure to get a full picture of how, not just the patient, but how that human being is doing in their recovery and their day-to-day after their experience. Because employers, maybe I'm altruistic, but employers want to take care of these people.
Well, let me add one thing here. So on the front end, we talk about recovery and we talk about, the anxiety, depression. A lot of what we do when we're managing these cases is take all the data that we can get. There are a lot of physical therapy entities that provide serial scoring. So they will provide quick dash scores on upper extremities. And we look at, high quick dash scores are predictive of anxiety and depression. They're also predictive of poor outcomes on things like shoulder surgeries. And so I may have a conversation with an orthopedic surgeon who is on the fence about whether or not they want to operate on somebody and say, okay, have you taken into consideration they have, diabetes, they're morbidly obese, they have a quick dash score that's off the chart, and they've had previous surgery on the other shoulder and didn't really do all that well. Have you taken all of that into consideration before you're going to actually cut on somebody? And 9 times out of 10, a lot of the surgeons will back out of making the recommendation for that surgery. And so you want to talk about dollar savings. Dollar savings is we saved a surgery. We saved a poor outcome.
So I guess what that tells me, which is a great segue into what we're going to talk about next, is sometimes investing a little time and effort and money up front can actually yield much better results on the back end. And I think that's really kind of the point of this whole panel discussion is we have to make sure that we're doing the right things up front. And even though I remember, so I spent some time as a state legislator, and I remember if we were looking at trying to save money in like our Medicaid system, and the legislative reaction was always, well, we should just cut provider fees, cut this, and you can score that savings pretty easily. My approach was, well, why don't we try giving them better care in this area or this area to help reduce the overall claim costs? Well, that's very hard to measure, and it's not very politically popular in the government. So when you're talking about investing a little time, a little effort up front, and so Scott, I want to segue to you on your Ohio study, where you did that very thing, where you were the Ohio Bureau, you studied what the Ohio Bureau was doing, and doing a little investment up front on those claims and getting better outcomes. So let's talk a little bit about that. So this is your slide.
Well, Ohio is a little unusual for workers' compensation. It's a monopolistic state, which means if you're an employer in Ohio, you must purchase workers' comp insurance, but there's only one seller, and that's the state of Ohio itself, specifically the Bureau of Workers' Compensation. Now, the Bureau engages managed care organizations to handle the claims for it, but the Bureau itself maintains the provider network of all the doctors that handle workers' comp cases in Ohio. And in Ohio, there is no direction of care. If you're an injured employee, you can go to any one of those doctors you want to. Well, the Bureau wanted to speed things up and eliminate red tape, so they implemented a pilot program in 16 counties for knee injuries. And the goal of the pilot was to get injured employees in to see a doctor faster. The goal was 2 days. The pilot actually got it down to 4. They also wanted to give the doctors more flexibility in treating these knee injuries. So they allowed the doctor to begin treatment as soon as the MCO approved the case, rather than having to wait for the MCO to approve the treatment plan. The pilot also simplified the authorization process in the forms and made a point of educating the employee about their injury. And the results of the pilot were fantastic. They saved $2.1 million and it cut return to work by 30%. Now, interestingly, when we evaluated the pilot and how it had done, we sliced and diced things in multiple ways. One way is in those 16 counties, we had 2 buckets. We had the injuries in the pilot and the injuries that were not in the pilot, handled the traditional way. That was the control group. We also sliced things into different buckets like non-serious knee injuries and more serious knee injuries, which were defined as knee injuries that were possibly going to require surgery. Now, interestingly, for the non-serious injuries, which were 75% of all injuries, the pilot cost more. And the reasons were because the pilot required each injured employee to go to see the doctor at the doctor's office. They just couldn't go to the emergency room or the urgent care center. The pilot also used physical therapy a lot more often than the traditional way. And then, of course, the doctors got a 15% bump in their fees for participating in the pilot. But that extra cost was overwhelmingly drowned out by the results on the more serious knee injuries. Only 25% of the injuries, but they accounted for 83% of the costs. And for those more serious injuries, the average cost of a knee injury in the pilot was 19% less than in the control group. Another thing that was interesting, although there wasn't enough data to make a statistical conclusion, was the pilot seemed to be much better at controlling outliers, those cases that careen out of control. In the control group, 2.6% of those cases eventually became outliers with an average cost of $235,000. In the pilot, however, only 1.4% of the cases became outliers, and they only cost $181,000. Then across the board, whether a serious injury or a non-serious injury, the pilot decreased return to work by 30%.
Okay, thank you. And then we did a study in
Brian, I just, personally, when I read this study, I was like, that is astonishing. That by spending more up front, you saved how much in the back end?
2.1 million.
I mean, that's astonishing. I mean, for employers that are worried about the bottom line, which seems to be a pervasive discussion here in trying to control the cost of workers' comp. Again, I'm just an injured person. I'm not a workers' comp person. That the effort to control the cost, when I read this study, it was just stunning to me. That what the solution was cutting costs, but the solution was figuring out a system to improve outcomes, which for me was about optimizing patients and helping them be educated and all that kind of stuff. So the bottom line is that if you're doing a better job of educating and guiding the injured worker, you're going to save 30%, maybe? Yeah, it's amazing.
And talk a little bit about the Fort Worth study, which I also found fairly fascinating.
Fort Worth is a lot different than the Ohio case study. In 34 states, including Texas, where Fort Worth is, you can direct care. So in some form or fashion, you can tell that injured employee where they have to go. So we looked at the city of Fort Worth's data, and we identified using outcome analytics the best doctors for treating each type of injury. And then the city formed a network of those doctors, those very best doctors, injury by injury, to which their employees had to go. And it ended up decreasing the city's workers' comp costs 23%. Now, when we looked at the city of Fort Worth, we looked at their workers' comp data set and analyzed that, but we also looked at their health plan data set. And that allowed us to do two things that were very helpful. First of all, I mentioned the importance of risk scoring, giving doctors credit for taking more care of more complex cases. And the biggest component of risk scoring, you have age, you have sex, but the comorbidities. Are they obese? Do they have diabetes? Well, most workers' comp data sets for insurers and TPAs don't have that. If you're an employer, however, you do have that. It's just not in your workers' comp data set, it's over in your health plan data set. So when we looked at the health plan data set, we could find those comorbidities so that when we were ranking the doctors and evaluating them, we were doing so on a level playing field. We were giving doctors credit for taking care of more complex patients. The other thing that this allowed us to do was we were able to spot great doctors not in the workers' comp data set. They weren't handling workers' comp cases for the city, but they were doing health plan work, and they were able to find those great doctors and invite them to join this new network. And as I said, it ended up dropping the city's cost 23%.
Okay, thank you. And Dr. Tonn, you have a very unique perspective because you work both in the non-subscriber system in Texas, and then you also work in insured systems in other states and in Texas. So there's a difference in the regulatory structure, some of the rules of the game, I think, a little bit. And so I want to talk a little about two things. One is, how do you look at evaluating providers and outcomes? And are there regulatory constraints or things that are happening in the insured world, in the more regulated world than you see in the non-subscriber system in Texas? Are there differences in the rules you have to follow that have an impact on outcomes?
Well, Scott said something, interesting, that they had to go into the Fort Worth health benefit data to get the comorbidity information on a workers' compensation case. And what I started out saying earlier today is, so we start looking at the claim much earlier on. We get the referrals based on referral criteria that will tag things earlier on, so that it's not at 120 days or at 9 months that somebody has been treating for some condition. We try to get them within the first couple of weeks at least, based on this referral criteria, and then make a determination of who is the next best provider for them to see. Is it actually an orthopedic surgeon? If they don't have something surgical, we don't need to refer them to an orthopedic surgeon because we're just wasting the orthopedic surgeon's time. So in the non-subscriber injury benefit world, we can direct care, but we also have employers who, as a result of this alternative, electing this alternative, they have now accepted the exposure on a negligence liability claim and are much more interested in taking care of the individual and determining what they actually owe for in that extent of injury. So we can get the cases earlier, we direct them based on what the case actually is rather than just a knee-jerk, they went to the clinic and got an orthopedic surgery referral. And then we look at how these different doctors interact with these patients. But our case managers are really focusing in on comorbid medical conditions. And we go as far, and this because of the referrals that the optimized outcomes get, is we go as far as to make sure somebody's diabetes is actually under control. We've actually diagnosed a lot of people with diabetes because we'll get a hemoglobin A1C on somebody who we suspect is a diabetic. We'll get vitamin D levels. We go above and beyond what is typical in the standard statutory workers' comp.
Thank you. And Blake, just how does I'm thinking about, in sales, when I was in sales, I learned winners keep score. So if someone's looking at if you have a patient that's really, looking at their self-assessment score and managing that and doing that on a regular basis, how does that, is there an impact or a psychological impact or some emotional benefit for them, like just keeping score of their progress and being engaged at that level?
Yeah, well, in the world of data collection and patient engagement, the biggest question is always, how do I get compliance? How do I get my patients to participate? And, short of putting signs up in your clinic and having providers remind them and having case managers remind them, the best way is to provide an experience that makes patients want to keep coming back. And the way that we do that at OccMD is show them how much better they're doing. It seems kind of simple, but there's not a lot of our competitors out there that are really doing this. There's really not a lot of competitors that take into consideration the actual patient experience. It's kind of, okay, fill out this questionnaire, thanks, moving along now. But with OutcomeMD, patients get a text or an email, they click it, they go online, hey, your pre-op score was 32, let's go ahead and take your survey today. They take it, hey, your score is now 78, you improved, here's what that means. Do you want to click this button to go online and recommend Dr. Brian on Google or Yelp with a data-driven recommendation? It's a very tidy way to provide a sticky patient experience and also a good mechanism for patients to promote that data-driven recommendation online. And physicians love it, and patients love it too, because it's simple and they want to get better.
Yeah, let me pile on that.
Yeah, no, and I was going to come to you next.
Well, yeah, I think in talking to patients, on the phone, people typically, benchmark where they were before they got hurt. And so there's 2 months into their recovery and they're just not right yet. And they go, oh, gee, I'm not getting better. They start to get depressed, and they get depressed and they stop trying, and then the whole thing goes down the drain. So what we're doing is saying, okay, here's your score right after surgery. It was 30, now it's 50. You're actually getting better. Oh, yeah, I guess I am getting better. Because when they look at the graph, and they look at those charts, they go, okay, terrific, I'm getting better. And they get recommitted and re-engaged in their recovery, which is, I think, the whole point of this discussion, is how to keep the patient engaged in their recovery, how to keep them doing what they need to do to get better, to get them back to work. Best phone call ever. I called somebody up and said, "Can I, you got time for a call?" They go, "No, I can't talk right now. I'm back to work." Well, okay, I don't need to be calling you anymore. Those are the kind of calls that we got in this programming working with OccMD, is getting people back to work in a time frame that was quicker than we really expected.
And so we're almost out of time, and I just want to close on one thought. I really want to go to Scott and Dr. Tonn on this. Cheaper isn't always cheaper, and in your studies you did some evaluation of the cost of a service versus the outcome. And could you just briefly explain this in about one and a half minutes?
1.5 minutes, 45 seconds per slide?
Yeah, if you
Okay.
kind of just distill that down for me.
Sure. Well, the slide on the left here, we're looking at the average medical costs for 14 specialists treating back patients. And we graph them there according to specialist one, the best one at about $1,000 per patient average medical cost, to the worst one, specialist 14 there on the far right, $8,600 per cost. But the medical costs are just half the equation. You also have to add in those absence costs. How long is this doctor keeping their employees off of work? And when you do that, we add in the average absence costs there on the graph at the right. Now specialist 2, who was second best according to their medical costs, becomes the second worst one in this whole data set. And specialist 9 was doing a better job than we originally thought. Their medical costs might have been a little higher than the other folks, but they were getting their employees better and back to work faster. So they actually were doing a better job, and if you reordered them, they'd be closer to number 1 than they are now.
And Dr. Tonn, you're looking at lots of different services that you're providing to the people under your tutelage. What are you looking at beyond just the cost of the services? I mean, is the cost of the service the discriminator, or can you spend a little bit more money and get better outcomes?
So, in workers' compensation, it's all about getting the lowest cost of whatever the unit is. So, the lowest cost MRI facility. Well, the lowest cost MRI facility often equates to the lowest quality MRI films. And it also equates to the lowest quality, cheapest radiologist who's reading those films. And looking at overreads on a lot of these films that are performed at these low-cost entities, when we get them overread, there's a dramatic difference in the read if we send it to a musculoskeletal radiologist. So if we have an MRI, the MRI is supposed to be the gold standard, the objective, of what your extent of injury is, and we have a misread, poor image to go by. At the end of the day, it's going to end up costing so much more money. It may cost an unnecessary surgery. We may have to redo it, and we also have to undo the damage with patients when people are told that there's something on an MRI that actually isn't there. And to undo that is to try to convince somebody who is already anxious, who is already catastrophizing about something, that the presence of this abnormality on the MRI isn't your extent of injury and doesn't establish causation with you lifting that box is a conversation that we'd like to avoid. So no, cheaper isn't always cheaper.
Once the wrong leg's cut off, it's hard to get them back,
Yeah.
right? I get that. Well, we're out of time. I just want to thank you all for being here. We have a minute for questions. If anyone has a question you'd like to ask, we have books up here that Harvey's willing to sign and give to you. Thank you again for being here. Thank you to the conference for allowing us to be here. I hope you found this worthwhile. And I think the messages from the panelists is, think about what you're doing. Spend a little time, effort, and maybe invest a little money up front on these claims to get to better outcomes. It'll save you tons of money in the long run. You'll have happier workers, and you'll have more productive workers when they get back to work. So thank you all for what you do. Bless you all. Have a safe trip home. Thank you.